Okay, so me again, and I'm really going to try and be a bit more brief this time because I'm thinking about lunch already. And so I'm just going to talk to you about custom treatments here. But before I do, just to kind of follow on from Vincenzo's talk here, for a bit of orientation in terms of patient information for refractive surgery and what messages to put over to your patients, have a look at the Royal College website in the UK, because we've got some information that we've done a big exercise, all of us together in the UK, about what we agree on, what are the right messages for patients undergoing refractive surgery. And the good thing about this information is that it's two things. One is that it's derived from patient research about what questions are important to our patients, and there's a list of them on the side here. And so these are the questions that are at the front of people's minds when they're coming to you. And the second important thing is that the answers were developed with both consensus opinion based on the evidence-based, but also the most important thing of all is patient input. So we had patients making sure that what we were writing was easily understandable. And let me tell you, it's the hardest thing in the world to write information when you're a doctor that actually does make sense to the people that it's for. You know, it really is. So have a look on the college website. You just got to navigate through it a bit. The college website in the UK is awful. And to find things, you have to really know where to look. And so if you just look under standards and publications there, you'll find it under refractive surgery there. But it's free to air, that you can use this information if you want to make any translation you like. And that's, I think, useful for you. Customized treatments. As you know, these days we don't just routinely drive laser vision correction treatments with manifest refraction alone. That's not the only option, at least. We also can use wavefront sensors to create an optical map of the eye, and you can design a treatment and then you can print that treatment back onto the cornea with modern tracking systems and treatment registration systems. So most laser systems have used something called Shack-Hartman aberrometry, and the way that works is with a grid of spots that are projected from sampling light as it bounces back from the retina through the pupil, and you get a sensor array, which is the Hartman-Shack sensor, that is designed to pick up a spot of light at each point over the array as it emerges from the pupil. And it knows where the spot of light is supposed to emerge, if it's an ideal wavefront. If the ray of light is deviated to one side or another, the distance of deviation from the ideal locus gives you information about the wavefronts. That's how Shack-Hartman sensors worked. And they were the basis of most common laser systems until recently. And we've now got a pyramidal sensor, which is a newer form of wavefront scanning, and that's based on a different principle. You just split the light into 4 images of the pupil, and by looking at differences between the light intensity between these 4 images, you can derive information about the wavefront, similar to that you get from Hartman-Shack sensors. And the big advantage of these systems is something called spot crossover. So the problem with Hartman-Shack sensors is because, remember, I was telling you that the distance between the point, the locus, the point of light emerges in an ideal wavefront, and the distance it's actually emerging tells you how distorted the wavefront is. Now, if you get a really uneven cornea, irregular astigmatism, in other words, the cases we really want to treat with a wavefront treatment, the abnormal corneas, well, Shack-Hartman sensors can't pick them up because the distance is so large between where you're expecting the light to come and the sensor to which it's addressed, is that the neighboring sensor is trying to read the light emerging. You get scrambled information, and so you can't image the irregular corneas, the ones you really want to get information from, with standard Shack-Hartman sensors, and pyramidal sensors allow you to do that. So with irregular astigmatism, we're going to talk about this. These are the common causes. You've got old-style refractive treatments like the RK, the radial keratotomy case that Vincenzo just showed. You've got the post-corneal transplant cases, the ectasias, and the post-infective cases that we talked about earlier. You've got a scar that's been there for a year, it's stable, the patient's unhappy, they've got irregular astigmatism. What are you going to do? So you can approach irregular astigmatism in this way. First of all, I think just so you all understand why we're talking about contact lens testing, a rigid contact lens gives you a perfect optical surface, so it neutralizes any irregular astigmatism. That's why it's such a good diagnostic test. If somebody sees badly in spectacles but well in a rigid contact lens, then you know that the difference is due to irregular astigmatism. A pinhole test is the next best thing. It's not quite as good as a rigid contact lens in determining what somebody would see if they had a good corneal shape. So first message in correcting irregular astigmatism is that the lasers don't do big adjustments, okay? They're for fine tuning. So this speaks to Zizis, I can't say Zizis says. It speaks to the point of Zizis earlier on, that he didn't want to treat the 380 micron cornea, remember? Well, I'd agree with Zizis if we're talking about big changes to the shape, okay, but we're generally not. For vision around about the 0.5 level, it's small adjustments. And so then you're getting into the laser territory. So if it's a big gross shape adjustment, you've got things like wedge excisions, you've got ring implants, you've got keratoplasty, all these ways of really doing a big shape reboot to the cornea. Having done that, you've got your fine tuning, and that's what the lasers do, okay, small adjustments. And then you can correct the lower orders, in other words, people's residual spectacle prescription once the spectacle corrected visual acuity is good, using other techniques like add-on lenses. First thing you need to know about any measurement in ophthalmology, including wavefront sensing, but it could be intraocular pressure, it could be your epithelial thickness on OCT. You need to know how repeatable is that measurement. In other words, if I do this measurement twice, is the second measurement going to agree exactly with the first measurement? Well, no, it never does, okay, in biological systems. But you can put a number on how much that variation is, and it's called the coefficient of repeatability, and that's the likelihood that, or that's the range of measures within which 19 times out of 20 your second measurement will lie. Okay, so it's an idea of how repeatable a measurement is, and this is the real reason why we like wavefront guided treatments from refractive surgery, because measurement repeatability for most wavefront scanners is about twice as good as it is for manifest refraction, asking the patient better or worse, right? Not very accurate. Okay, so it's more repeatable using wavefront guided autorefraction. So that's one of the reasons for doing wavefront guided treatments. And I'm going to skip through this. This is some information about measurement repeatability in wavefront scanning. So to get repeatable measurements, a very good tip in anything you're doing in ophthalmology is to have a standard set of instructions that your technician gives to the patient. In other words, put your head forwards against the bar, put your chin forwards against the stop. Don't tilt your chin from one side to the other. Keep your focus relaxed. You can find your own form of words, but it needs to be the same thing every time. So train your technicians to do that for you. And in wavefront scanning, the other important tip for you is make it the first thing you do. So before the patient's tear film, they've squeezed because they've had a big photopic stimulus, and they've got a lot of meibomian secretions breaking up the tear film. Get 3 scans off quickly if you can, and make it the first measurement you do, and then you tend to get more accurate results. Now, what do you do when you're programming a treatment? If it's a custom treatment and your manifest refraction is telling you one thing and your wavefront refraction is telling you another thing, and this is something called a Bland-Altman plot here, which is a standard measure of the difference between measurements with 2 techniques. The message here is that we can get more than a diopter difference between the manifest refraction and the wavefront refraction quite often. And so which measurement do you choose to do the treatment? Well, the answer is both of them, okay? Because they both have useful information. Although manifest refraction is less repeatable than wavefront guided autorefraction, it's less prone to problems with accommodation, because people tend to accommodate when they're looking at a near target on a sensor. And also, it's what matters to the patient in the end, is their subjective refraction. And so it's useful information. And when you want to use information from 2 things to feed into your, or more things, to feed into what you're programming into the treatment, you use a technique called regression analysis. And nowadays, people are also talking about machine learning to do these kind of exercises for you. Again, I'm not going to say any more. If you're really interested, take a photograph of that slide, read the paper. It walks you through how that's done, okay? But my father was a woodwork teacher, and he always used to say to me, measure twice, cut once, okay? So in other words, if you've got two different ways of looking at a measurement, use the information from both sources, okay? Very simple. And now we've got good printers these days, modern laser systems. They have very good treatment registration, and they have very accurate tracking. And so we've now got very good printers, if you like, for printing our treatment back onto the cornea. And these are some results with in ordinary corneas, so routine myopic wavefront guided LASIK. And they're about as good as it gets. About 19 people out of 20 are in the really good group, okay? They're seeing 1, I think, in the decimal system, what we call 6.6 or above. And they're within half a spectacle unit of the ideal refractive target. It doesn't get much better than that, because remember about measurement repeatability, you've got optometrists. If you have 2 optometrists refracting the same patient, 1 time in 20, they'll be more than half a diopter apart anyway. And so if you see somebody saying they get 99% within plus or minus 0.5, you know they are in refractive surgery fairyland, okay, as we say. So just a little something to be aware of there. So close to the theoretical limit, and very good in astigmatism. Wavefront guided treatments do give you an edge there. Do they give you supervision? Do wavefront guided treatments allow you to see better than normal people with normal vision? In other words, you know, kind of 6.2 unaided or something like that. They don't, okay? So if we look at aberrations before and after, they're the same, but they're not worse. And that's progress, because when we started in refractive surgery, corneas were more aberrated after laser vision correction than they were in a normal untreated cornea, and that's no longer true, and that's one thing that wavefront guided treatments give you. So where are we in 2019? We're going to hear about this in the debate, SMILE versus LASIK later. I'm looking forward to that. Bottom line is all the treatments work really well, okay? And the difference between them are really small. And so you can decide for yourself which modality you like best, and you can run with that, and you'll get good results because the technology is there, okay? And I would say that if you look at, this is a network meta-analysis, and it's a way of looking at the literature in a structured way. The big dots there show you the treatments we've done a lot of trials in. Where the smaller dots, there's less information. And the thickness of the line here tells you how many trials compare these different modalities. And so we know a lot more about the older techniques, that's true. What we know in 2019 is that thin flap femto LASIK is still the gold standard, but the other treatments all work. Irregular astigmatism, let's remind ourselves these are the common causes. And remember, we're not going to do gross adjustments with the laser, we're only doing the fine tuning. And this would be a typical example I'm going to set up here, which is how we treat keratoconus with early visual loss. Okay, and again, you can photograph this slide if you're interested in going over this in more detail. So the question here is, can we use trans-PRK? And I'm just going to show you a trans-PRK treatment here, almost live, to help reduce irregular astigmatism in cases presenting to you with keratoconus and visual loss in one eye. And this treatment, this is a modern surface laser treatment. It couldn't be simpler. We just take a registration photograph, put the speculum in, and deliver the treatment before the tear film breaks up. And so it's no-touch surgery. It's easy to do. It's easy to repeat. It's safe, but it's painful. So the reason we still have LASIK and SMILE is because of pain after treatment. That's primarily it. Also, whereas with the vision recovering quite quickly with the interfacial treatments like LASIK and SMILE, the patients even the next day are seeing quite well. With a surface laser treatment, it takes about 2 months to 3 months to catch up to where you would have been if you'd had LASIK done. But that's the treatment. It's as simple as that. The ablation pattern goes down, and that's the treatment done. And these days we use mitomycin to control scarring and haze. We use Casicol to accelerate healing. But still, there's about 48 to 72 hours of significant discomfort afterwards. The patients need a week off work. When somebody solves that problem, and they will, then we won't be doing LASIK or SMILE anymore. So in your combination with cross-linking, what are you trying to do? Well, versus cross-linking alone, you're trying to improve the corneal shape and you're trying to improve vision. But you're trying to improve vision in spectacles. We're not trying to treat myopia or astigmatism because spectacles do that, right? Or an ICL implant later. We're trying to get better vision in spectacles. And the advantage versus sequential treatment, in other words, cross-linking first, then waiting for the corneal shape to stabilize, if it ever does, and then doing laser treatment later, is that it doesn't seem to make intuitive sense to me to strengthen the superficial corneal tissue, then ablate it away 2 years later. It may destabilize the cornea. And if you've already cross-linked the cornea, then you're more likely to get a stronger haze reaction, and there's also an undercorrection that you need to factor in. So also, it's one painful episode rather than two if you combine the treatments at the same time. So it's a very nice and elegant way of approaching it. But we would all agree that you want to remove the minimum amount of tissue required to improve the vision in spectacles. How much tissue are we removing? Remember that 380 micron cornea that didn't want to touch? We're doing small adjustments here, okay? So in the typical cases we're treating, which would be people with a vision at around about the driving standard or poor visual quality between 20/20 and the 20/40 level, we're removing typically about 35 microns of stroma, so not a large amount. And the interesting thing is that when we program these patterns, by the way, topography-guided treatments do worse than wavefront-guided treatments, and the reason for that, in terms of tissue removal, is that in the ectasias, you get if you trace a light wave through an ectatic cornea, you get a compensatory effect from the posterior cornea, and so wavefront-guided treatments take that into account and therefore remove less tissue. So if we instruct the laser with the system we're using at Morpheus, is the Schwind-Damaris, and it's got a clever programming trick, we can say to the laser, only correct the higher order aberrations, okay? Now, here's an important point for the people who are interested in refractive surgery. What we used to do an optical zone expansion, treat an irregular shape, or treat an ectasia, or something like that, or a post-infective scar, is if we didn't want to make any difference to the sphere and the cylinder, we used to say to the laser, 0 in the attempted sphere box and type 0 into the attempted cylinder box. And then tell the laser, well, we just want you to do a wavefront treatment or a topography-guided treatment. What happens then? The laser understands that instruction like this. It says, right, I'm going to do the shape change to correct the irregularity. Now I'm going to do a calculation and see how much change to the sphere and the cylinder I've made by doing that shape change. And you wanted 0, so I'm going to do a second tissue removal to make that back to 0 again, okay? And it turns out, if you do the maths on this, the second bit removes a lot more tissue than the first bit. So we want to tell the laser, we don't care where the sphere and cylinder ends up because we can correct that with spectacles. We just want to correct the irregularity. And that way we end up removing much lower tissue depths. Here's a typical ablation pattern in keratoconus. And the point to make about this is that most often the deepest ablation is in this compensatory arc at the top, where we're steepening the top of the cornea and flattening the bottom. Remember, typical keratoconus shape is a little bulge down the bottom. Coma is the dominant aberration. And we almost always get this pattern of treatment. So a bit of tissue removal over the peak, the apex of the cone here, and an arc at the top here. What are the results clinically? So here are 4 random cases from our series of 50. 4 consecutive cases selected at random. Okay, so these are the kind of results that we're getting. Okay, so a good flattening over the tip of the cone, steepening over the top, and centralization of the vertex. Improvement, but not perfection. But people are getting worthwhile gains in visual quality. So better than cross-linking alone, we think. It certainly gives better vision if we do a statistical test on this. We've got cross-linking only on this side, and we've got the combined treatments here. Interestingly, we did see some improvements with the cross-linking alone, but we saw bigger gains with the combined treatments. You'd expect that. And patients were typically taken from around about the driving standard, poor visual quality, to better visual quality, something closer to 20/20. We were getting a lot more visual gainers where we did combined treatments than with the cross-linking alone. And we were getting keratometric stability. One thing about modern cross-linking treatments is they don't progressively flatten the cornea so much as the old-style Dresden protocol treatments did. We were getting reductions in cylinder, and patients were getting a bit of a myopic drift, and that's the way the ablations worked. One point to make about keratoconus manifest refraction is that optometrists are trying to refract coma as cylinder. And so you get, a poor result in terms of acuity and an attempt to fit a toric lens shape over a coma aberration. What else can we do? Well, we can concentrate the cross-linking energy in one point over the cornea rather than distributing it evenly. And this is not a refractively neutral treatment. The aim is to flatten the cornea where you're delivering most UV light intensity. And this is another approach to customized treatment in keratoconus. The risk with this is something called reverse ectasia. Spelt reverse wrong there, sorry about that. And so what is that? Well, a worry about cross-linking. It took actually about 10, 15 years for us to discover that radial keratotomy caused progressive corneal flattening, about a diopter a decade. It took the PERC study, which was a 10-year prospective study done by George Waring back in the late 80s, to discover this. We are seeing some flattening after routine cross-linking in keratoconus. And in some cases, and Theo Steyer has described this, we're seeing progressive flattening that doesn't stop after 10 years. Now that's bad, not good, okay? And the concern is if you're putting a high-density UV treatment over one spot in the cornea, will we get this reverse ectasia in more patients? So although curve on the one hand, you're not removing tissue, on the other hand, you may risk progressive flattening. We don't know, we'll find out. But what we do know is the combined cross-linking and laser treatments appear to be stable. It doesn't appear to impair cross-linking efficacy. So we'll leave it there. And as usual, I have no sense of time, so I've probably gone right into lunchtime there. But I hope we still have time for the other speakers, do we?
This is a question for you. Not question,
Right.
not question, comment.
You just allow me a comment, yes. So, treating irregular astigmatism in an ectatic cornea is, in my opinion, and I think we all agree on that, a completely different story compared to treating irregular astigmatism in a non-ectatic cornea. So, there is a certain hype about combined procedures. However, we don't have much evidence in terms of stability, long-term stability, safety, and reproducibility of the results. The only group that published results, long-term results, 10-year results, was the Athens protocol FATHER, showing, as always, excellent results. But all other modified protocols are lacking stability results, long-term results, and safety results. We don't really know what is the refractive effect of cross-linking, accelerated cross-linking. We know very much about the Dresden protocol, and we know a lot about biomechanical effects of accelerated cross-linking or other types of cross-linking, but the flattening effect, the long-term refractive effect of accelerated cross-linking, I think we need to know much more about this. In my opinion, refractive procedures in terms of wavefront guided or PAK combined with cross-linking should be spared for selective patients, patients who are willing to take some risk, because there is always a risk in this procedure, and patients who are desperate to have their vision improved. We also see patients, I've seen patients where I could only treat about 20% of the coma, and there was very minimal increase in visual acuity, because I'm a big fan of this procedure. So how can we explain the failure of the visual outcome in patients where we don't have a full treatment range, where we only can correct certain amount of the aberration error, because we just see and adjust our ablation depth based on the refraction of the patient. Can we quantify, or have we quantified, what is the minimum of amount of aberration error that we need to correct so that the patient has a meaningful improvement in his visual acuity? I think we don't. That's why I'm reluctant on advising any patient with mild or moderate conus to be treated with these protocols. I think we should And we are customizing this procedure for certain patients. So this is the message that I would like to send to all of you. And I would like to hear Bruce's opinion on that.
Have we got time?
Yes.
Okay.
We do have such a comment. I forgot the first sentence of the comment. That's quite a comment.
So I'll try and be brief. Okay, so we covered treatment stability, okay? In other words, does laser treatment destabilize the cornea? Is it any better or worse than cross-linking alone, right? And lack of evidence, okay?
Refractive effect of the cross-linking, of accelerated cross-linking after a modified PRK.
Okay,
we didn't look at that.
Yeah.
There are no studies on that.
Okay.
Long-term studies on that.
Right. So the publication standard is 2 years, okay, in cross-linking. That's we don't have 10-year data. You're quite right about that. And we may not find out what cross-linking is really doing
We don't
for a long time.
It's getting worse at some, I'm not talking about the wavefront. The wavefront treatment is the soft treatment. I'm not talking about topo-guided treatments or PRK treatment where you can also have really risk for deterioration or of the ectasia over time. But the evidence is just not there yet. The results are amazing, but you also have a threshold in your correction. So how can you tell that a patient where you can only correct up to 20-30% of his aberration profile will profit significantly? And what is significant? What is meaningful? A patient who comes from 0.2 to 0.3 might not be a happy patient because.
So we had stability first, and we got vision. Okay, they're the two important questions in keratoconus. The first thing you've got to do is stabilize the corneal shape. The second thing you've got to do, if you can, is improve vision. Okay, everyone agrees? Yep. Stability and vision. Okay. So we've got to practice evidence-based medicine. This is quite right about that, and the evidence base is incomplete. However, we do have some evidence, certainly out to 2 and 3 years, published, that there's no difference between cross-linking alone and light-touch customized treatments for keratoconus. So we're not talking about taking off more than 50 microns, which is the number pulled out of the air, I believe, by John Candelopoulos when he started the whole field, okay? So nobody is going more aggressive than that. But within those limits, the published data we have shows no difference between cross-linking alone and trans-PRK and cross-linking. And these are studies that are powered to pick a difference up. So I think we're fairly confident about stability. What we don't know about stability is what all of our cross-linking is doing to the corneal shape long-term. What we do know from the Moorfields data, which will be published, which I've seen, so I've got a bit of an advantage over Zizis here, on accelerated cross-linking, which we've been doing since 2012 there, is that it's more stable than the Dresden protocol. We don't see flattening routinely, at least not a large amount. This is new. What we do see is an average of 0.2 diopters per year, okay, of flattening. Now, you may say, well, who cares? Quarter of a diopter a year. Do the maths, okay? Remember that radial keratotomy, it's 1 diopter a decade. If you're doing quarter of a diopter a year, you're getting 1 diopter every 4 years. So we don't know yet how whether that result is going to stand up over time. The reason being that our data was loaded towards the first 2 years after treatment. So we see some flattening, a small amount. We don't know whether it's going to be a lot in the long term. So this is right. There's a question mark, okay? But I'm pretty confident about stability. And in terms of visual improvement, I mean, that one's really simple. So the do-nothing option doesn't give you any visual improvement, okay, or not much. Whereas if you do a custom treatment, you do get jumps in acuity.
Just come back to what the patient is expecting again.
So again, you have to be realistic. It's an improvement. It's not a total solution. And I think that speaks to Vincenzo's point about counseling surgeons before surgery. You know, in general, is that it's very important that you're clear that what you're going to do is going to improve them. Is it going to deliver perfection? Maybe not.
One final issue, which is do not arm. So if you don't arm, like your study seems to show, probably it's worthwhile to try to go for some improvement anyway.
I think we have to move on to the next talk, which will be thesis for refractive surgery results complications, and quality of vision.